Our next topic is peripheral vascular disease, and we're going to talk about both arterial and venous peripheral vascular disease. Let's start with arterial. What you will see is rubor or redness. The skin will be cool and shiny. There may be ulcers. The patient may develop gangrene. There will be intermittent claudication, and you'll remember that that is pain with exercise that is relieved by rest. There may be impaired sensation and a decrease in the peripheral pulses. The type of arterial peripheral vascular disease you may see is Raynaud's disease, Berger's disease, and arteriosclerosis. The type of predisposing factors to this type of problem: smoking, exposure to cold, emotional stress can play a component, diabetes mellitus, a high-fat diet, hypertension, and obesity. Let's take a look at the implementation for arterial peripheral vascular disease. First and foremost, you'll want to monitor peripheral pulses. You need to make sure the patient provides good foot care, and you will do teaching regarding that. The patient should not cross their legs, should wear good fitting shoes. If they smoke, you want them to stop smoking. They should engage in a regular form of exercise, and the type of medications they use are vasodilators and anticoagulants. And if the type of peripheral vascular disease is Raynaud's disease, they will do a sympathomectomy. Let's talk about venous peripheral vascular disease. The type of assessment or what you will see with the patients is they will have cool brown skin. They may develop edema. Their pulses might be decreased, but they also might be normal. And they will have a positive Hohmann sign. Remember, Hohmann sign is with dorsiflexion of the foot, there's pain in the calf. The type of predisposing factors you will see to development of venous peripheral vascular disease are immobility, pregnancy, heredity. Again, obesity can play a role. Sometimes they develop after surgery. It can develop after an injury to the vein wall, and hypercoagulability, again, can cause this. Let's talk about the implementation for venous peripheral vascular disease. Again, you'll want to monitor peripheral pulses. The patients may wear elastic stockings, such as TED hose. The medications, again, are anticoagulants. These patients should elevate their legs, and the reason you want to elevate the legs is to promote venous return. They will use warm, moist packs, and you want to make sure that they check the temperature of the packs before applying them. And in the acute phase of a venous peripheral vascular disease, such as thrombophlebitis, the patient will be put on bed rest 4 to 7 days. Another type of venous peripheral vascular disease that is commonly seen is varicose veins. Let's go on to a slightly different topic, and that is hypertension. Now, hypertension, what you may see, first of all, you may see no symptoms at all. The patient may be asymptomatic, or they may complain of headache, dizziness, they may experience retinal hemorrhages, and they may have inguinal pain. And again, remember, hypertension is the persistent elevation of the systolic blood pressure above 140 millimeters of mercury, and an elevation of the diastolic blood pressure persistently above 90 millimeters of mercury. There are several risk factors for the development of hypertension. These are things such as family history. If you have a high sodium intake, you're more predisposed to develop hypertension. Physical inactivity could lead to it. Excessive alcohol intake. Some other contributing factors would be a stressful lifestyle. When you talk about hypertension, it's either primary, essential, or idiopathic, meaning they're not sure what the cause is, and this is about 90% of all the cases of hypertension. Again, the hypertension can be benign or malignant, and the benign usually has a gradual onset and a prolonged course. The malignant has a very abrupt onset and a short, dramatic course. And again, we said that the hypertension can be primary or essential. It can also be secondary, meaning it comes from another cause. Things such as cardiovascular disease can result in hypertension. Renal problems can. Adrenal problems, again, can cause hypertension. Let's take a look at the implementation for hypertension. Well, the medications used are the hypertensives. These are things such as Aldomet and Serpacil, and we talked about the different antihypertensive medications and how they worked in the pharmacological and parenteral unit. And again, do review those medications and know about the antihypertensives, how they work, and what the nursing responsibilities are. Another implementation for hypertension is if the patient is obese, overweight, you should put them, or they should be put on a weight reduction diet. If they are in a high stressful job or situation, again, the patient will want to make lifestyle changes. Might be change of a job, relaxation or meditation, might be a regular exercise regime to help with working with stress. And again, there's a lot of teaching that you'll do with the patients that have hypertension, and about the lifestyle changes, but also about dietary changes. They may need to reduce sodium in their diet. You'll want to teach them about medications. And again, there gets to be a safety issue with many of the medications that patients take for hypertension. Many of them cause orthostatic hypotension, so you need to caution your patient to change positions very slowly, so they get up and sit for a few minutes before they stand. They don't just bound out of bed, because they may fall over because of the orthostatic hypotension. Let's go on and talk about anemia. And anemia, the type of symptoms you will see are palpitations, dyspnea. The patient may be diaphoretic. They may complain of chronic fatigue, and they may be very sensitive to cold. And you remember that anemia is a decrease in the number of erythrocytes or reduction in the hemoglobin amount. And when you talk about anemia, it can be mild, and that's where you'll get the milder symptoms, the palpitations and the dyspnea. It can be moderate. Here, the patient has the chronic fatigue, or it can be severe. And those patients are more likely to complain of sensitivity to cold. Let's talk about the implementation for anemia. Well, first and foremost, you want to find out why the patient's anemic, because the treatment and the nursing care will depend on what the cause is. Also, you want to provide or make sure the patient knows to take frequent rest periods. They should be put on a high protein, high iron, high vitamin diet. And again, you want to make sure to protect them from infection. We're going to talk now about a couple different types of anemia that are commonly seen and commonly tested on the NCLEX. The first is iron deficiency anemia. And the type of assessment you will see, again, the patient complains of fatigue. They complain of glossitis, which is inflammation of the tongue. They have spoon fingernails, and they have impaired cognition. It's hard for them to remember things or keep track of things. They feel like their brain is a little fuzzy. This is the most common, iron deficiency anemia is the most common type of anemia that patients have, usually caused by a decrease in intake or malabsorption problem. GI tumors and things such as that can cause it, as can excessive menstrual bleeding. Let's take a look at the implementation or what you do for iron deficiency anemia. Well, what you want to do is you want to increase the patient's intake of iron-rich foods. These would be things such as liver and green leafy vegetables. And again, they may take iron supplements. They may take it IM or IV. And again, the type of things we talked about with pharmacological and parenteral therapies about the iron staining the teeth and causing constipation, that's all the type of, or all of that should be included in the teaching that you do with this patient. Another type of anemia is called pernicious anemia. And pernicious anemia happens when the gastric mucosa fails to secrete enough of what they call the intrinsic factor so that the stomach can absorb vitamin B12. This is diagnosed by the Schilling's test, and we talked about the Schilling's test in our reduction of risk area. But what you will see with pernicious anemia, the patient will complain of fatigue. They will have a sore red tongue, and that's very characteristic of the disease. And they may complain of paresthesia or numbness in the hands and feet. The implementation for pernicious anemia is they will get vitamin B12 IM, and it will be, can't take it PO because, again, would not be absorbed. They will take it IM, and they will need it for the rest of their life. Another type of anemia we're going to talk about is sickle cell anemia. And remember that sickle cell anemia is a severe hemolytic anemia that results from a defectively shaped hemoglobin. The hemoglobin becomes sickle-shaped in the presence of low oxygen. And symptoms are caused, or in what we'll talk about, are caused by the hemolysis and the thrombosis that goes with it. The type of symptoms you'll see with sickle cell anemia, the patient will complain of pain, and it will be moderate to severe pain. They will experience swelling. They may have a fever. Their sclera will be jaundiced. They may have tachycardia, and with that they might also have cardiac murmurs. The type of treatment or implementation that is done for sickle cell anemia, well, first of all, you want to check for signs of infection, because if the patient becomes infected, it will cause them to go into crisis. You also want to check the joint areas for pain and swelling. You want to encourage fluids, because again, dehydration can promote crisis for sickle cell anemia. If the patient, you want to encourage fluids, you want to provide analgesics. And again, because the pain is moderate to severe, they use a PCA pump with medications such as morphine sulfate, especially during crisis. Okay. Another type, this is not an anemia, but it is a blood disorder, is hemophilia. You'll remember that hemophilia is a sex-linked disease transmitted to the male from the female carrier. And it's a deficiency, the most common type, hemophilia A, is a deficiency in factor VIII. The type of assessment you will see is the easy bruising. These usually is diagnosed when with children or infants, and they will have bruises on their body from unexplained areas. They'll always have areas of ecchymosis. They will complain of joint pain, and they will have prolonged bleeding. For example, if they get hit in the nose with a ball or something, their nose will bleed for a long period of time. Under implementation, what they will be administered is plasma that contains the clotting factors, or actually factor VIII. They will get, or should get, analgesics, again because of the pain involved, the joint pain. But remember, you do not use the NSAIDs or aspirin, because they decrease platelet aggregation, and that would promote excessive bleeding with these patients, which is exactly what they don't need. They can get the cryoprecipitated antihemolytic factor, or AHF. That can be given, and again, you want to teach these patients, and many of them, as I said, are children. You want to work with the families about lifestyle changes. This is not the child, if it's a boy, who should go out for the football team. Golf is good, tennis is good, non-contact sports are better. Okay, we're going to leave kind of what we've been talking about with blood disorders, and we're going to now talk about pituitary disorders. And the first one we're going to talk about is dwarfism. With dwarfism, you have a hyposecretion of growth hormone, and this occurs before maturity. What you will see is and the thing to remember between dwarfism, and then we're going to talk about acromegaly. With dwarfism, the body proportions are normal, meaning the head is in the same relationship as it would be, to the arms and trunk, but it's just smaller than normal. These patients these people have very fine skin, very delicate features, and their height is below normal when you look at it on a growth chart. Implementation, you want to monitor growth and development, again, as they progress through. They use hormone replacement therapy, and what they use is human growth hormone, also thyroid growth hormone, and testosterone. So again, you want to teach the patient and the parents in many cases, because this is diagnosed early, about the medications and how and when they should be taken. Another pituitary disorder is acromegaly. Acromegaly is hypersecretion of growth hormone that occurs after maturity. So what you see here is kind of the opposite of dwarfism. The body size is enlarged, but because it happens after maturity, it doesn't happen evenly. They're not just evenly enlarged. Different parts are larger than others. The patients will complain of poor coordination, and they will experience visual changes. Treatment for this, or implementation, you want to monitor blood sugar, because that can be a problem. They use implants with Atrium-90, and again, whenever we talk about radioactive implants, you need to remember the care that goes with those particular treatments. And they can do a hypophosectomy, and again, the type of post-op care that would be needed would go with that. Again, a couple things about the care after the implant. Usually it is implanted nasally, so you want to observe nasal discharge. Sometimes they will administer antibiotics to go along with it. The patient, because it is a nasally implanted radiation treatment, they should avoid blowing their nose, and you don't want them to sneeze. Again, while the implant is in place, you want to make sure and monitor their vision, because if their vision changes and they begin having visual disturbances, it could indicate that the transplant has been misplaced. And again, when this type of thing is going on, you want to monitor level of consciousness and things such as that. Okay, we're going to go on and talk about a topic that is, again, frequently tested on the NCLEX, and that is cancer. With cancer, the type of things you need to know care for radiotherapy, both external radiation and internal radiation. And you need to know the medications, the chemotherapeutic agents that are used. Let's take a look at cancer. The American Cancer Society has warning signs that spell caution, and if you look down on the slide, you can see that the very first letter on the left side spells out caution. And these are things, again, that the general public should be educated about. With cancer, you will see a change in bowel and bladder habits. You will see a sore that does not heal. There may be unusual bleeding. There may be thickening or a lump. The patient may complain of indigestion or difficulty swallowing. There may be an obvious change in a wart or a mole, and there may be a nagging cough or hoarseness. This discussion of physiological adaptation. Physiological adaptation will be about 11 to 17% of the questions you'll see on your NCLEX exam. And today we're going to be discussing things such as cardiac, respiratory problems, medical emergencies, and fluid and electrolyte balance. Let us begin. First of all, we will talk about medical emergencies. And the first medical emergency we will talk about is upper airway obstruction. What you need to know are how to do the Heimlich maneuver, how to perform CPR, tracheostomy care, and care of a patient on a ventilator. Okay, upper airway obstruction. What you will see with the patient is they will be unable to speak. And if someone appears to be choking, that's one of the first things that you'll do is ask them if they can speak. If they can't speak, you know that the airway is totally occluded, and you have only a couple minutes to get that airway open and patent again. The patient may become cyanotic or blue, and again, death will occur within 4 to 5 minutes if the airway is not reestablished. What we'll do for implementation, the first thing you should think about when someone is choking, often happens in a restaurant, is the Heimlich maneuver. And let's talk about the Heimlich maneuver. You will stand behind the person that is choking once you have determined that they cannot speak, and you will wrap your arms around their waist. And what you will do is you will make a fist with one hand and put the thumb side of your fist against the patient's chest. And then you will wrap your other hand around the other part of your fist. So the thumb side of my fist is against the patient with my arms around them, and I'm going to press the fist into the abdomen with quick upward thrusts, and I may do this several times. It may be necessary to repeat it. Now, when I do this, something flies out of the patient's mouth or the person's mouth, and they say, "Oh, thank goodness, you saved my life." Well, then you know they can speak, and you know that the airway is now patent again. If you have a patient that is quite obese or is pregnant, you will use chest thrusts instead of abdominal thrusts. Another way to deal with upper airway obstruction is to intubate the patient. And there's 2 ways that patients can be intubated. The first is with an endotracheal tube. This is a tube that is passed through the nose or mouth into the trachea. And what you will do once an endotracheal tube is passed is you will check for breath sounds bilaterally and bilateral chest excursion or movement of the chest with respirations. You will mark the tube where it touches the nose or mouth and secure it with tape to stabilize it. Other than the endotracheal tube, you can also do a tracheostomy. And you'll remember that a tracheostomy is a surgical incision into the trachea, and then a tube is placed in it to provide for an airway. We talk in our reduction of risk tape about the tracheostomy and the tracheal tube with cuff. And remember, the purpose of the cuff with the trach tube is to prevent aspiration. It is not used to secure placement of the tube. So it is to prevent aspiration. And you would want to maintain cuff pressure if the tracheostomy tube you're using has a cuff. Now, one of the other things with a tracheostomy or the endotracheal tube is you want to make sure that that tube stays patent. And the most important way that you're going to do that is by suctioning the patient as needed. One frequently asked question on NCLEX is, how would you know the patient needed to be suctioned? Someone that had an endotracheal tube or a trach. And again, very important information. You would know it if the patient began to have noisy respirations, meaning you can hear them breathe in and out. You would see it especially if the patient became restless, because as their O2 drops, they will get restless because of the cerebral anoxia. You will see it with an increase in pulse rate. You will see it with an increase in respiratory rate as the body tries to compensate for the fact it's not getting oxygenated. Or you'll actually hear or see presence of mucus in the airway. So again, very important to know when to suction with patients that have been intubated or have a tracheostomy. One other thing we do for upper airway obstruction is mechanical ventilation. And let's talk about that. For someone that is being mechanically ventilated, you will listen to breath sounds. And the type of things you're listening for are your rales, your rhonchi. You are hoping that you will hear equal breath sounds on both sides. And if the breath sounds are unequal or decreased or absent, you would know that there is a problem. Again, patients that are on mechanical ventilation may have other respiratory monitoring devices, such as a pulse oximetry in place. You want to evaluate their ABGs, or arterial blood gases. That tells you how well the body is being oxygenated. And again, even though the patient's on mechanical ventilation, you can't rely on the equipment to evaluate your patient. You need to rely on what you see. So you will be assessing your patient very frequently for signs of hypoxia. And those would be things such as restlessness. They may become anxious. They may become cyanotic. They may have tachycardia, or there may be an increase in respiratory rate. Again, signs of hypoxia are frequently tested on the NCLEX. Patients that are on mechanical ventilation, again, you need very good oral hygiene to keep the mucous membranes moist and free of debris. And one of the key things that with mechanical ventilation and with many of the equipment pieces we're going to be talking about today, again, this is frequently tested on the NCLEX. You need to make sure and care for the patient first and the equipment second. So if an alarm starts going off and you run into the room, the first thing you will look at is the patient, not the equipment. Okay, patients that are on mechanical ventilation, one of the other things also is we do want to check settings and check alarms, and these should be set so that if something does go wrong, you will be notified of it. But patients on mechanical ventilation no longer can speak, so you will need to establish a different way for them to communicate with you. Could be paper and pencil, could be a magic slate or some kind of board to write on, but you need to make sure and establish some way that they can communicate with you, because they can't talk. And again, you need to make sure that you document all observations and all assessments that you do. And sometimes condensation will form in the tubing of the mechanical ventilation device. And you'll need to make sure that that condensation is drained periodically. Let's talk about another problem, and this would be cardiopulmonary arrest. You would know a patient is in cardiopulmonary arrest is if they are breathless, meaning they do not appear to be breathing, if they are pulseless, and for an adult you're going to check the carotid pulse. For an infant you're going to check the brachial pulse. We don't check their carotid pulse because infants have very fat necks and it's very hard to palpate the carotids. And you will also know that your patient is in cardiopulmonary arrest if, in addition to being breathless and pulseless, they are unconscious. Now, if you do not establish ventilation within a 4 to 6 minute period, your patient will experience cerebral anoxia and along with that brain damage. So it's imperative to start CPR as soon as you determine the fact that they are pulseless, breathless, and unconscious. And the first thing you're going to do is shake and shout. Because again, if maybe their respirations are very quiet and shallow and they're not moving. You don't want to start CPR on someone who happens to be deeply asleep. So you would shake the patient, Mr. Jones, Mr. Jones, shouting at them to see if they are rousable. It will be one way you will be able to determine unconsciousness. The second thing you will do is you will summon help. You don't want to be all alone in this situation. So as soon as you determine that this patient needs help, you will get someone, dial 911, scream, get someone to help you because you're going to need help. The very next thing you'll do, and again, this happens almost instantaneously, is you will open the airway. It may be a head tilt or a chin lift, but you need to get that airway open. The next thing, once you establish what you think is the airway, you're going to look, listen, and feel for signs of breathing. Because sometimes just the repositioning to get the airway open is all that the patient needs to reestablish ventilations. If it doesn't happen, shaken them and you've opened the airway, no breathing, there's no apparent breathing, you will then pinch the nose and give 2 full breaths. And as you give the 2 full breaths, you'll want to watch and make sure the chest rises. Now, if you give 2 breaths and nothing happens, the chest didn't even move, you don't have a patent airway. And you might as well blow in their ear as blow in their mouth. So what you want to do is reposition the client again, blow again, and again you will watch the chest rise to make sure you have a patent airway. Now, with breathing with CPR, what you will do is adults, you will do mouth to mouth, 12 breaths per minute. If it's an infant, you will do mouth to mouth or mouth to nose at 20 breaths per infant, or per minute, 20 breaths per minute. And then after you do that, you will check the pulse. And again, with an adult, you will check the carotid pulse. With an infant, you'll check the brachial pulse. If there is no pulse, you will then begin cardiac compressions. And this is when you'll actually use your 2 hands and you will push on the patient's chest. And again, adult, for chest compressions, you use the heel of the hand. For infants, again, they are much smaller people, you will use 2 or 3 fingers. That's how you will do the chest compressions. Because in an adult, what you're looking for is you are looking to compress the sternum about 1.5 inches at a rate of 80 to 100 compressions per minute. So again, it's a certain depth you're looking at. You wouldn't just kind of barely touch them, but the other thing also is you're not looking to break their ribs or provide injury here. So again, you want to provide chest compressions to depress the sternum 1.5 inches at a rate of 80 to 100 for an adult. With an infant, you want to use 2 or 3 fingers to compress the chest 1/2 inch to 1 inch, and the rate is 100 per minute. Now, so you've started chest compressions, and then you will start doing breaths and chest compressions, and the way that it happens, whether you have 1 or 2 rescuers, for an adult you will do 15 compressions to 2 breaths, and you will do 4 cycles of that, and then you will reassess the pulse and the breathing. For an infant, again, you will do 15 compressions to 2 breaths. You will do 20 cycles of that and then reassess the pulse and breathing. If the pulse returns, and many times it does, and the patient only requires rescue breathing, for an adult you will do rescue breathing at 12 breaths per minute. If the infant, again, the pulse returns, you have a pulse that you've checked, and it's there, you will now just do rescue breathing, and it will be 20 breaths per minute. Okay, one of the issues or questions that happens on the NCLEX periodically is they want to know when you can stop CPR. Okay, good question, because when can you stop? Well, the happy ending to that particular question is when the victim responds. If you get a pulse back and then the patient begins to have spontaneous respirations, you can stop. That's a happy ending. You can also stop when someone else takes over. You can also stop, and that's why, remember, you called for help because you don't want to be there all by yourself. You can stop when the patient is transferred to someone else's care. And the sad story is if you are doing this alone out in the middle of no place on a path in the woods, you will do it as long as you are physically able to do it. And then you will stop because you will be unable to continue. And the reality is that if the patient did not respond with both spontaneous breathing and a pulse rate, they probably, the prognosis was poor from the beginning. Hello and welcome. I'm Dr. Judith Burkhardt, Executive Director of the Nursing Programs for Kaplan, and welcome to this continuation of a discussion of reduction of risk potential. We talked about preoperative care for patients and then intraoperative care. Our patient has made it successfully through surgery, and now we're going to be talking about postoperative care. The first and most important thing to do postoperatively for a patient is to make sure that they maintain a patent airway. And if the patient does suffer an obstruction, what you need to do is tilt their head back and push forward on the angle of the lower jaw to open up the airway. The second most important thing you need to do is to prevent hypotension and shock. And usually this is accomplished by the infusion of IVs to provide for volume replacement. After the patient comes back from surgery, you want to stimulate them to help them recover from the anesthesia. You want to monitor their level of consciousness. You want to check their vital signs almost continuously. And if the blood pressure, the systolic blood pressure, falls less than 90 millimeters of mercury, this should be reported. Also, you would compare their post-op blood pressure with what happened when they were before surgery. If they had a stable blood pressure before surgery and after surgery you're seeing a downward trend of 5 millimeters of mercury, when you check it at each of the 15-minute intervals, that also should be reported. You want to work with the patient and monitor their intake and output. You will be monitoring central venous pressure for many of the patients after surgery. You want to monitor their electrolytes, especially potassium. You'll listen for breath sounds, and you'll work with the patient to relieve any pain and anxiety that they have. Going on with post-op care, again, it's important to turn, cough, and deep breathe the patient unless it's contraindicated because of the type of surgery that they had. And if the patient has a wound, again, preoperatively, hopefully you taught them how to splint their incision for the coughing, turning, and deep breathing, and they would splint the incision when they did it postoperatively. Pain management is important. And again, prevention should be done rather than pain control. And many times patients will come back from surgery and they have a PCA pump, which is the patient-controlled analgesic pump. Because what this does is it promotes participation in their care and eliminates any delay in administration of pain medications. But it's important that the patient be able to understand both the need to self-medicate or self-dose, and they have to be physically able to do it. So if someone weren't able to move and press the button to administer the dosage of medication, they would not be a good candidate for a PCA pump. Other things you do after surgery, they use an incentive spirometer, again, to make sure that they have good lung function. You'll check for bowel sounds. Remember, the anesthesia makes the bowel sounds go away, and you're listening carefully in the 4 quadrants for the return of bowel sounds. Patients are NPO until the gag reflex returns, and again, during this time, you want to provide good mouth care. Again, you'll check for passage of stool and flatus, because that tells you that peristalsis has been reestablished. Let's continue with postoperative care. You want to check pulses, the peripheral pulses, to make sure that there's no problem with circulation. After surgery, the patient should be taught not to cross their legs, and they should not elevate the knee gauge on the bed because it puts pressure on the popliteal space. Some patients will have external pneumatic compression stockings after surgery. Again, this helps with venous return. It encourages the blood to return from the lower extremities back to the heart. Some patients will be put on low-dose heparin sub-Q, again, to prevent any clotting complications postoperatively. And you do want to check a post-op patient, for Homan sign. And you'll remember that Homan sign is pain when the ankle is dorsiflected. This is one of the first symptoms of deep vein thrombosis. It might also be accompanied by a cramp or a pain in the calf. Again, sometimes the patient will be put on low-dose heparin given sub-Q until they're up and ambulatory, and the danger of the deep vein thrombosis is somewhat minimized. Going on with postoperative care, you want to check the incision. You're looking for the appearance of it. Are the edges approximated? What is the drainage? What does it look like? How much drainage is there? And again, that should be documented, both the amount and the character of the drainage. All care you give to the patient with regard to the incision or the wound needs aseptic or sterile technique. All the dressing changes, everything should be done according to the sterile procedure. Okay, now we're going to talk about some of the complications of surgery. And again, these are the things that we work to prevent, but sometimes they happen. The first complication we're going to be looking at is hemorrhage. And hemorrhage is seen, or what the symptoms are that you will see is the patient becomes apprehensive. They're restless. And if you see a patient kind of apprehensive and restless in bed, you should check them over because this is significant and may indicate hemorrhage. They also may complain of thirst. Other things you'll see is a decrease in blood pressure and an increase in pulse. But you don't want to wait for the vital signs to change before you begin assessing the patient, because by then there might be a significant amount of blood loss. Again, if they go into or if they have hemorrhage after surgery, their skin will become cold and clammy. Again, remember, pulse increases, temperature increases, the respirations become deep and rapid. They experience what's known as air hunger. What you want to do if the patient is experiencing hemorrhage is you want to report it to the physician. You want to monitor vital signs very closely, and blood volume will be replaced. The next complication is something somewhat similar, which is shock. Again, with shock, could be caused by hemorrhage, could be caused by vasomotor disturbances, or several other things. What you'll see for symptoms of shock, again, a decrease in blood pressure, an increase in pulse, and the cold, clammy skin. Again, the implementation for shock, whatever the cause of shock is, whether it's hypovolemic shock, you would replace volume. If it's some other type of shock, you might deal with the vasomotor system, that type of thing, but you'll treat the cause. Patients will be given oxygen, and they will be given IV fluids. The next complication of surgery we're going to talk about is atelectasis and pneumonia. Again, hopefully we've worked hard and are working with the patients after surgery to prevent this. We're having them turn, cough, and deep breathe, use the incentive spirometer, but sometimes this will happen. The symptoms you will see for a patient with atelectasis and pneumonia, they'll have dyspnea or difficulty breathing. They'll become cyanotic or the blue color, and they will have a cough. They usually experience tachycardia, they may have a fever, and there is pain on the affected side. Now, the treatment for atelectasis and pneumonia, the patient should be suctioned to keep the airway open. You want to cough, have them cough, deep breathe, and turn every 2 hours. Again, you want to teach them again how to use the incentive spirometer and make sure they use it routinely while they're awake. And also antibiotics, especially IV antibiotics, are given for the pneumonia. Another complication of surgery is embolism. The symptoms you'll see for a patient who is suffering an embolism, again, they have dyspnea or difficulty breathing. They have pain. They have hemoptysis, which is the bloody sputum. They, again, are very restless. They've been calm, and now they're kind of restless in bed. They have this feeling of impending doom. When you check their ABGs, and you will, you'll find a low O2 and a high CO2. The treatment for embolism is they will be given oxygen, they will be given heparin, and they will be given IV fluids. The next complication we're going to talk about is DVT, or deep vein thrombosis. Again, this is what we were checking for, remember, when we talked a few minutes ago about post-op care. When patients have deep vein thrombosis, they will have a positive Homan sign. Again, remember, that's pain when the ankle is dorsiflected. The treatment for deep vein thrombosis is anticoagulants, and heparin is the drug of choice. The next complication of surgery is paralytic ileus. Remember, the intestinal movement stops because of the anesthesia. If it fails to be reestablished, then paralytic ileus results. What you will see with paralytic ileus is there will be absent bowel sounds. There'll be no passage of flatus or stool postoperatively after the amount of time where you usually would see it happen. The treatment for paralytic ileus, they will put an NG tube down, attach it to suction for decompression. They will put the patient on IVs if they're not already on IV fluids, and they may need a decompression tube, one of the tubes we talked about before, the Miller-Abbott or the Cantor tube, to decompress the bowel. Another complication after surgery is infection. The type of risk factors you may see are people who are more likely to develop an infection after surgery. First of all is age. The older the patient is, the more likely they are to develop an infection. Nutritional status. If they are in poor nutritional status preoperatively, then they are more likely to develop an infection postoperatively. That's why a lot of times before surgery, patients will have TPN or high protein diet to get them in good shape for surgery. Diabetics are more prone to infection. People who smoke are more prone to infection postoperatively. Patients that are obese, again, are more prone to infection. And again, the longer your preoperative stay, meaning if you come into the hospital a week before you have your surgery done, again, you're more prone to infection than the person who comes in the day before or the day of surgery. Also, the severity of the illness. People with chronic problems are more likely to develop infections than patients or people who don't have chronic problems. Under assessment, what you will see for patients with infection postoperatively, there will be leukocytosis, which again, remember, is an elevation in the WBC. They will have fever, and when you do a culture, and a culture will be done if there's drainage, that will be positive for an organism. The type of nursing care and treatment you do for infection after surgery, the patient will be put on antibiotics, usually IV. Again, you want to reestablish and make sure that all care of the patient takes place with aseptic or sterile technique. And again, good nutrition. The physician may order TPN for the patient or a high protein diet, something to help reestablish good nutrition for good wound healing. Another complication is dehiscence, and you'll remember that dehiscence is disruption of the surgical incision. What you do if the patient experiences this is you will put them in low Fowler's position, no coughing is allowed, the patient is instantly NPO, and you will notify the physician. The next complication is one that sometimes happens along with the dehiscence, and this is evisceration. With evisceration, not only do you have the separation of the wound edges, but you have protrusion of the contents that were inside the wound. So there's protrusion of the wound contents to the outside. This is a medical emergency, and what you need to do, again, you need to put the patient in low Fowler's position, no coughing, they will instantly become NPO, and the viscera that is now protruding from the incision, you will cover it with the sterile saline dressing and notify the physician. And what will happen is the patient will be taken back to surgery, the incision will be opened and then redone, everything packed back into place, and then the incision closed again. Okay, other complications of surgery. Another one is urinary retention. This happens sometimes after surgery because the system that lets a person know that they should void isn't working properly. So the person either doesn't have the stimulus to void or is unable to void. And when you palpate, and you will, for bladder distension, you will find that the bladder is distended. The treatment for this is the patient will be either straight cast or have an indwelling Foley catheterization as needed. The next complication after surgery is urinary infection, and sometimes happens if the patient has had a Foley catheter implanted or put in place during surgery. The symptoms you'll see for urinary infection, there'll be foul-smelling urine and leukocytosis. The type of treatment that is done for urinary infection, the patient will be put on antibiotics and fluids are forced. And again, remember, normal intake is about 1,500 cc's per day. So if you're forcing fluids, you're forcing to about 3,000 cc's per day. Another complication of surgery, you don't see it often, but it can happen, and that is psychosis. What you will see if the patient has this complication is they will have an inappropriate affect, meaning the way that they behave or the way that they respond to things is inappropriate given the situation. The treatment for psychosis following surgery is will use therapeutic communication, and sometimes medications are used. Okay, that concludes our discussion of perioperative care We're going to now talk about diagnostic tests. Hello and welcome. I'm Dr. Judith Burkhardt, Executive Director of the Nursing Programs for Kaplan, and welcome to this discussion of reduction of risk potential. Reduction of risk will comprise about 13 to 19% of the questions you'll see on your actual NCLEX exam. And we're going to be talking about things such as sensory and perceptual alterations, alterations in body systems, perioperative care, diagnostic tests, and therapeutic procedures. Let's begin. We'll start first with sensory and perceptual alterations, and these are problems with the eyes and ears. We're going to talk first about impaired vision and what you need to know. And when I say what you need to know for the exam, essentially what I'm saying that these are topics that are frequently tested. So with impaired vision, what you need to know or what's frequently tested are visual function tests, disorders of accommodation, care of a blind client, and how to instill eye drops. With impaired vision, what you'll see is redness in the eyes, there may be burning and eye pain, there'll be lacrimation, which is tears, and sometimes it will be accompanied by exudate. The patient may complain of a headache, they may squint, there may be changes in growth and development, especially if the patient is a child, and there may be visual disturbances. For visual function tests, the first one we're going to talk about is tonometry. And tonometry measures interocular pressure. It measures the degree of indentation on the cornea when pressure is applied, and it is the test used to test for glaucoma. The second type of test we're going to talk about for visual function test is the test that assesses peripheral vision. And essentially you're seated and you are looking ahead and you fix on a point in the center, and usually you can see 50 degrees up or superiorly, 90 degrees laterally or to the side, 70 degrees inferiorly or down, and 60 degrees medially or inward. The last type of visual function test we're going to talk about is the Snellen. And this is the eye chart we're all familiar with the very large E. To perform the test, the patient stands about 20 feet from the chart, they cover one eye, and they read the smallest letter that is visible to them. And what the test does is you compare the results to what a normal person could see at 20 feet. Let's talk about disorders of accommodation, and the first one we're going to talk about is myopia. This is nearsighted. These patients have deeper eyeballs, and the image focuses in front of the retina, and they have blurred distance vision, so they can see near, but they have difficulty with far vision. The second type of disorder of accommodation is hyperopia. These are far-sighted patients. They can see clearly far, but they have difficulty or blurred vision when they look up close. Another disorder of accommodation is presbyopia. This happens to most of us after we're 35 years old due to changes due to aging. The last disorder of accommodation is astigmatism. This is a result of uneven curvature of the lens, and there's decreased acuity both for near and far vision. Let's talk a little bit about burns of the eye. There's different causes to burns of the eye. They can be chemical, such as acids or cleansers. It can happen because of radiation, sun, lightning, someone watching an eclipse, or there can be thermal burns due to hot liquids. With implementation, the type of things you will do with burns of the eye, if they're chemical burns, you will irrigate the eye for 15 to 20 minutes. If you are dealing with a radiation burn, it's difficult to treat them, but the best thing to do is to prevent them. So you would talk with people about, going outside with sunglasses on, not watching eclipses, and preventive measures. For thermal burns, again, it's best to prevent them, so you would teach people to wear goggles to prevent them. If a thermal burn does occur, they will patch them after injury, and the patient will be given analgesics. Eye trauma is another disorder or problem with the eye. Again, it's best to prevent eye trauma, and the way to do it, especially with children, is to provide safe toys. Nothing that has pieces that will shoot out or injure the eyes. Also, if you're an adult, if you're working with chemicals or tools outside or children doing sports, they should wear eye protectors at all times. For implementation with eye trauma, if it's a non-penetrating abrasion, they will patch the eye for 24 hours. If it is a non-penetrating contusion, meaning something bounces off the eye, they will use cold compresses and analgesics. If it's a penetrating eye injury, meaning something has entered the eye itself, you will put the eye patch on, you will immediately go and get emergency help, and they will do surgery to remove the foreign object in the eye. Another thing you'll need to do is to be able to care for the blind client. And it's important to do this because it is frequently tested on the exam. When you're caring for a blind client, you'll want to address them by name so they'll know that you're talking with them. You should introduce yourself and state the reason that you're there. You should let them know what you're doing as you're working with them in the room. And of course, let them know when you leave the room, otherwise you leave and they're still talking with you because they don't know that you have gone. It's important that you kind of orient them to the room and let them know where the furniture is in the room so they can navigate around. And it's essential to keep the furniture where it is so you don't move things. You keep them in the spot where they originally were. Doors should be either open or closed. They shouldn't be half open because that would be a danger to a blind client. When the blind client is walking, they will be, many times they'll walk with an attendant, and the attendant should be half a step ahead, and the client lightly touches the attendant and walks with them. When you're presenting a food tray to a blind client, you'll want to let them know where the food is on the tray, and usually you'll use hands of the clock. Your peas are at 12 o'clock, the milk is at 2, the different places. When blind clients navigate or walk alone, many of them will use a walking stick. The goal in dealing with blind clients essentially is to foster independence and to provide assistance only as needed. Another disorder of eye is retinopathy of prematurity, or ROP. Essentially, this is where there's immature blood vessels in the retina of a newborn. They constrict and become necrotic. There's injury to the developing capillaries. It usually occurs or frequently occurs in infants of low birth weight, that is under 3 pounds 8 ounces, or infants of short gestational age, meaning before 28 weeks. The ROP, or retinopathy of prematurity, is due to high concentrations of oxygen. They cause constriction of the retinal vessels, and that causes them to become necrotic. Now, essentially what you need to know about ROP that's frequently tested is the relationship of oxygen and ROP, and you'll also should know that you see it with respiratory distress. It happens with artificial ventilation, apnea, bradycardia, heart disease, hypoxia, acidosis, and with sepsis. So let's talk about retinopathy of prematurity. It's a diagnosis that is done by ophthalmic examination. The disease many times will not be manifested until about 4 to 6 weeks after birth, so it may not be something that you will see initially. What you'll see under assessment is there will be risk factors there. For example, prematurity or the low birth weight. And again, you should assess the infant's breathing efforts because the anoxia and problems with that, again, will lead to ROP. The treatment is they use cryotherapy or laser therapy to stop the progression of the disease. They may use a scleral buckling procedure, and vitrectomy is used if there is a retinal detachment present. Essentially, the type of nursing care you will do for an infant with ROP is you want to prevent the disease or the problem using minimal oxygen concentrations. You will monitor the infant's PO2, and the infant will undergo periodic eye examinations. Let's talk about strabismus. Remember, strabismus can be congenital or acquired. There's esotropia, which is inward where the eyes are crossed. There's exotropia, which are outward where they call it wall eyes, where the eyes go toward the outside. And many times with strabismus, the child or the person will close one eye in order to see, in order to focus. What you'll see under assessment is there will be deviation of the eye. When they look at you, they're not, one of the eye is not in line, is not parallel. There'll be diplopia, which is double vision, and the person may tilt their head or squint in order to see. The implementation, they use corrective lenses. They will sometimes use eye patching and exercises in order to strengthen the muscle on the eye that deviates. Sometimes surgery is done after eye patching if the eye patching does not work. Another type of thing similar to strabismus is amblyopia. That's known as a lazy eye, and it is sometimes or often due to untreated strabismus. Let's go on and talk about detached retina. Remember, the retina is neural tissue of the eye. It has rods and cones and photoreceptor cells that are found in a sensory layer. When that layer is stimulated by light, an electrical impulse is generated and transmitted to the brain. So what happens with the detached retina is there is separation of the retinal pigment epithelium from the sensory layer, so the layers actually separate. The risk of this are the people that are prone to retinal detachment. It happens sometimes with trauma. It happens with diabetic retinopathy. It happens if there's myopia. Patients that are aphakic or without a lens after cataract surgery, again, this can occur. The thing that you need to know that will be frequently tested are the symptoms of detached retina, the care after surgery, and the type of client teaching that you'll do. So let's talk about detached retina. What you'll see is there may be flashes of light. The patient will complain of loss of vision. They may complain of particles moving in the line of vision, or what they call them floaters moving in the vision. The patient may be confused because of the problem with sight, and it's frequently painless. There's no pain involved in the detachment. Let's talk about the type of treatment that you'll use. Patient with a detached retina will be put on bed rest with the eye in the dependent position, meaning if it were my right eye would be positioned down. The eyes will be patched, sometimes one eye, sometimes both eyes, and the patient will be prepared for surgery. Now, if gas is used during surgery, they will position the patient post-op face down or on their side for several days because the gas is used to put the layers back together. The type of care after surgery, the patient will receive sedatives and tranquilizers because they need to stay relatively still. You will teach them to avoid stooping or bending over. They should not strain at stool, and they should do no strenuous activity for 3 months while healing takes place in the area. You'll also teach them signs and symptoms of infection or increasing intracranial pressure, and they should know that when they see those signs, they should notify the physician immediately. Let's talk about cataracts. The type of things you need to know with cataracts is you need to know the care after surgery and especially the client teaching. Cataracts is the most common cause of visual impairment and the third most common cause of preventable blindness. What cataracts are is there is an opacity of the lens that prevents the refraction of light, and cataracts can be congenital or acquired. The type of symptoms you'll see under assessment, the vision will be distorted and will be blurred, and when you look at the patient, their pupil may appear milky white. It's a painless disease, so there's no pain involved in it, and again, their perception of color may change. The type of treatment that's done is surgery, usually done outpatient, usually done one eye at a time, and the two surgeries are separated by several weeks or several months. So let's talk about the patient undergoing surgery for cataract. Pre-op, again, you want to make sure to reduce the risk for hemorrhage, so patients that are on anticoagulants such as Coumadin or heparin, aspirin, NSAIDs, nonsteroidal anti-inflammatories, those should be withheld for several days before the procedure is done. And then they will instill dilating drops every 10 minutes times 4 before the surgery is performed. Post-op, they will put in eye drops, and the eye drops are antibiotics, they are anti-inflammatories, and corticosteroids. The patient will wear an eye patch for 24 hours, and in order to clean the eye, they will use a damp washcloth and just remove the secretions in the morning. The patient may complain of kind of a scratchy feeling for several days. The eye usually appears slightly red, and they may complain of blurred vision for either several days to several weeks. At night, they will wear an eye shield for the first 1 to 4 weeks so they don't injure the eye at night, and they're encouraged to sleep on the unaffected side. Let's talk about glaucoma. The type of things you need to know with glaucoma are the medications involved, which are miotics and the carbonic anhydrase inhibitors. And you'll remember that glaucoma is a condition characterized by optic nerve damage. There's an increase in the intracranial pressure that is caused by congestion of the aqueous humor of the eye. Remember, the aqueous humor flows between the iris and the lens, and it nourishes the cornea and the lens. Glaucoma is the leading cause of blindness in adults. You'll see it more often in patients older than 40 years old. It's more common in males, and especially African American and Asian descent. Let's talk about what you see. Well, they'll do a diagnosis based on the tonometry to measure the intraocular pressure, and we talked about that visual test before. They will use an ophthalmoscope to inspect the optic nerve. They will examine the filtration angle in the anterior chamber. They will, use the perimetry or peripheral test that we talked about to assess visual fields. The type of symptoms the patient usually complains of, they complain of blurred vision. When they see lights, the lights have halos around them. They have a decrease in peripheral vision, and you may pick that up first because you're here showing them something and they don't pick up on it. There is sometimes pain involved, and the patient may complain of a headache. For implementation, the goal is essentially to prevent further damage by maintaining the intraocular pressure within normal limits. And usually glaucoma is treated medically. Surgery is the last resort with glaucoma. What they will do is they will start the patient on low doses of a topical medication to see how effective they're going to be. They use cholinergics, which are miotics that increase the outflow outside. And remember, miotics are the things that constrict the pupil, and the way I remember it is the O in miotic is small. So it constricts the pupil so the aqueous humor can flow out. They use adrenergic agents, which are sympathomimetics. They use beta blockers. They use carbonic anhydrase inhibitors, because all of these things decrease the production of aqueous humor. The medication therapy for glaucoma is lifelong. You can't take it for a few years and then you're cured and don't have to do it. They'll do it for the rest of their life. And you do need to teach patients about drug interactions, because again, remember, this happens mainly with patients that are older, and many older patients have what I consider what people call polypharmia, meaning they have a lot of different medications for a lot of different disease processes. With glaucoma, they will use laser surgery, and after the surgery, the patient should know to avoid heavy lifting or straining at stool. Let's now talk about the ears, and the first thing we're going to talk about is hearing loss.
Hello and welcome. My name is Barbara Irwin. I'm the Director of Curriculum for Kaplan Nursing, and this is psychosocial integrity. Psychosocial integrity is 6 to 12% of the questions on your NCLEX RN exam. And while it's not a particularly large area, in fact, it's one of the smallest areas of the NCLEX RN blueprint, it's certainly very important, because regardless of where you work in nursing, you're going to be using the techniques and the theory in psychosocial integrity. You have to communicate therapeutically with whomever you communicate in nursing and also on the exam. We're also going to be talking about topics such as crisis intervention, death and dying, therapeutic communication techniques, bipolar illness, violent and aggressive behavior. So let's begin. These are some mental health concepts that you need to know. It's very important that you understand Maslow's hierarchy of needs, because this is going to help you select priority questions on the exam. Therapeutic communication techniques are tested throughout the exam, as is recognizing what is non-therapeutic communication and treatment modalities for mental illness. When you are assessing a client for their mental health, it doesn't matter what the setting. So the psychosocial assessment will be done for all clients in all settings. Now, if you are working in the psychiatric setting, the purpose of the psychiatric assessment is to establish rapport with the client. It's to understand what their current problems is. Also, you want to assess the client's current level of psychological functioning. It's important that you determine what the client and family goals are, as well as identify what needs need to be modified to assist the client to achieve positive changes. Now, when you first began your mental health assessment, the first thing you're going to do is observe your client. You're going to look at their appearance, their speech, and their sensorium. For example, are they well-groomed or are they unkempt? Are their clothes dirty? Is their hair dirty? What does this person's body language tell you? Are they relaxed and confident? Are they anxious and scared? You're going to be looking at speech patterns and thought processes. For example, are they speaking with you in just a relaxed conversational tone? Is their tone of voice high and they're speaking very, very quickly, like they're anxious or they're upset? It's important that you observe thought processes too. You know, does the conversation flow? Does the person respond to you in an appropriate way so you can have a conversation? Or is there a flight of ideas? Are they alert and oriented? Are they a good or poor historian? it's important that you be aware of their level of growth and development, because this helps you assess, are there issues with that, or is this not a problem? Certainly you want to look at family relationships and work habits, because these can be both a support to the client or it can be a stressor. So you want to look at support systems or stressors. It's also very important that you assess for risk factors, especially for suicide, homicide, or for substance abuse problems. Now let's talk about Maslow's hierarchy of needs, because it's very important to the NCLEX exam. This is a theory of human motivation, and Dr. Maslow says that all humans have 5 basic needs, and they have to be met in a hierarchy, and you can see what the hierarchy is. The most basic level, or the bottom of the pyramid, are physiological needs. This is food, water, air, clothing, shelter, and sex. So every client has to have these needs met first before they go to the next level, which is safety and security. And these are your psychosocial needs. Safety can be physical safety, it can be psychological safety. It's security for us. We feel safe, we feel like there's order in our lives. After safety and security, that need is met, then we go to loving and belonging. And this is where we're working on companionship, belonging to a family group or to a work group. The next level is self-esteem and recognition. And the person who's working on this level is trying to achieve status, success, or prestige. Now, the very highest level at the very top is self-actualization. And with self-actualization, this is the desire to know, to appreciate the truth and beauty and growth and fulfillment. Now, you're not going to be tested, what is the lowest level. That question isn't going to be there on your exam. But in classes, we're going to teach you how to use Maslow in order to help you establish priorities on the exam. So Maslow is very important to the test. Now let's talk about guidelines for communication. Communication can be both verbal and nonverbal. And the nonverbal communication is the most accurate reflection of a person's attitude. Now, when we talk about first the verbal communication, we're talking about the spoken and the written word. And in order to communicate successfully verbally, one has to understand the vocabulary, one has to know the context. The conversation has to occur in such a way that makes sense to both parties. Nonverbal communication is everything that does not involve the spoken word. So it's everything that's not spoken or written. Nonverbal communication is unconsciously motivated, and it is the most accurate reflection of the intended meaning. If you are dealing with a client, for example, and the client is a teenage male, and he's talking about his mother, and you ask, how are things going with your mother? Well, everything's fine. Well, you hear the words, everything's fine, but you also hear an angry attitude or an angry tone of voice. Well, this means there's incongruity between the spoken word and the nonverbal, the behavior that you're looking at, the tone of voice, the way the person looks, their body language. And when there's incongruity in that way, what we hear is the non-spoken or the non-verbal communication. So we hear the anger and not necessarily the spoken word, and we respond to the non-verbal. Now, when you're trying to evaluate a client's nonverbal communication, there's several things that you're going to look at. First of all, you're going to look at their physical appearance. Are they, how are they looking at you? Are they maintaining eye contact? Are they looking away? Are they sitting in a chair with their arms all folded really tight? What does that say to you? That they're not very open to the conversation. Maybe they're saying words that are okay sounding words, but you look at their face and you see anger. Certainly listening to the nonverbals, the sighs, the groans. How are you doing today? Fine. You know, again, there's incongruity there. Now, when you're evaluating eye contact, you must look at this within a cultural concept. Here in the United States, we do believe in direct eye contact. You know, we feel that's the appropriate way to communicate. But several cultures, for example, Hispanic cultures or Asian cultures, they feel that direct eye contact is a show of disrespect. So perhaps they won't maintain eye contact with you because they respect you as the nurse. And that, you know, you have to be aware of the cultural context. So you're going to be evaluating not only the verbal, but the nonverbal communication. Now let's talk about therapeutic communication. And you are going to be tested throughout the NCLEX on therapeutic communication. They're so very important because they convey the nurse's respect and acceptance of the client, and also it encourages the client to express feelings and ideas. Now, the goals for therapeutic communication are that we understand both the verbal and the nonverbal message, that we facilitate the client's verbalization of feelings, that we communicate as the nurse acceptance and understanding of the client, and that we identify problems, goals, and objectives. Now, the very first thing that you have to do in order to communicate therapeutically is you have to be committed to the concept of active listening. Now, in most settings, most like a med-surg setting, for example, that means that we would be facing the client directly. Now, in the psychiatric setting, many times, because of the issues going on with the client, to sit across from them and maintain this direct eye contact might be threatening. So in the psychiatric setting, perhaps you will be sitting side to side with the client, or you all will be sitting at a 90-degree angle, but you wouldn't be sitting across from each other. Be aware of your own body language. You need to have an open posture. I know for myself, for example, I like to sit with my arms folded like this because it's comfortable for me, but yet I'm conveying something negative to the client. You know, I'm conveying that I'm closed and I'm just really not interested in what they're saying. So be aware of your posture. Lean toward the client because you're conveying interest. Maintain intermittent contact. It doesn't have to be a direct gaze, but you know, you may look away and then you'll look back to the client. It's very important that you be relaxed. If you're tense, the person is going to pick up on it. Okay, let's talk about some specific therapeutic communication techniques. The first is, and I always find it kind of interesting, a communication technique, and it's silence. You have to be committed to sitting there quietly and allowing the client to take the lead. Sitting in silence allows the client time to think and also allows them to decide what they want to talk about. So you're going to sit quietly and wait. The second technique that you're going to use is you're going to use general leads and broad openings. The reason for this is you want them to direct the conversation. You're saying to them, I'm interested in what you have to say. So what you might say are, what are some of your concerns? Or tell me about your brothers and sisters. Something broad so that they can decide what they want to talk about. Another technique is called clarification. You will clarify the message. You're going to request feedback so that you clearly understand the message and that you are conveying to the client that you clearly understand the message. You clarify by using phrases such as, I'm not sure that I understand. In other words, you seem to be saying, or tell me more. The last therapeutic communication technique, which is very important, is reflection. You do want to reflect what the client is saying. And the reason that you reflect is it helps the client understand their own thoughts and feelings by sharing observations. You seem to be saying, or it sounds like you're feeling angry. Now, these are the therapeutic communication techniques, but on the test, you're also going to be asked to recognize non-therapeutic communication. So let's talk about non-therapeutic communication. Now, the reason it's considered non-therapeutic is because it is a block to effective communication. Either you've discouraged the client from expressing their feelings, or you're causing them to respond in a defensive way, and both of those are negatives. Now, the first non-therapeutic communication technique that you want to avoid is don't use close-ended or yes-no questions. The reason for this is it prevents sharing. For example, to say to the client, "Are you feeling better today?" "Yes." "Okay, now where do we go with the conversation?" But a more open-ended, "How are you feeling?" then the client's able to discuss what they want to. Another non-therapeutic communication technique is don't give advice. Now, I read this a lot of times, and I always find it somewhat amusing because I feel like in nursing, we're always instructing the patient, and we're always trying to help them, achieve whatever goals they're trying to achieve. But there's a therapeutic way to do it and a non-therapeutic way to do it. And if we are giving an advice, if we're telling a patient what they ought to be doing, in essence what we're doing is we're communicating to them, you're not capable of making your own decision. So we're interfering with their ability to make a decision. So it's very important that we don't make statements like, maybe an adult child is talking about the difficulty that she's having coping with her father who lives with them, and the nurse says, "Well, I think it's time for your father to go into a dependent living facility." That's us giving advice. Another non-therapeutic communication technique is having a nurse-centered conversation. And sometimes these can sound empathetic. You have a patient that says, "I think I had a panic attack yesterday." And the nurse responds, "Oh, yeah, I had a panic attack last week, and I thought I was going crazy." Well, now all of a sudden we're discussing the nurse. So remember, this is the patient's time, and we want to be focused on the patient. The other problem with having these nurse-centered conversations is it makes us defensive. If we have a patient who says to you, I think you're too young to be taking care of me." Well, if we start defending ourselves, "No, I'm not young. I may look young, but I've had 10 years of nursing experience." There is nothing good is going to come from it. So maybe what we should do is turn around and say to the patient, "Well, you have concerns, about your care." So don't have nurse-centered conversations. And the last one is don't argue. And that almost goes without saying, but sometimes we can literally be sucked into an argument with a patient before we really realize it. And the problem with arguing with the patient is we're basically telling them their perceptions aren't valid, that they're just simply not right. For example, you might have a patient who says to you, "I didn't get a wink of sleep last night." And as a nurse, you say, "Well, I came in here at 2 o'clock last night and you were snoring." Now, you might say, "Okay, I'm presenting reality." No, you're arguing with the client. So what you need to do is reflect the feeling tone. You feel that you're not rested this morning. So be really comfortable with the non-therapeutic communication techniques because they're going to be your wrong answers on the NCLEX exam. Okay, we have some more non-therapeutic communication techniques here. Another one is don't reassure the client. And again, some people say, "Well, what's wrong with reassuring the client?" Well, what's wrong with it is you're underrating or undervaluing their feelings. If a client says, "I'm really concerned about something that's happening next week," and you respond, "Oh, don't worry about it, everything's going to be fine." Well, here is this poor client, and they've just said they're worried, and we've said, oh, forget about it. So you're not going to reassure the client. You're also not going to ask why questions. Why did you do that? Why did you make that decision? Because it implies criticism and disapproval, and it makes them be defensive, just as it would make all of us get defensive. So you want to focus on who, what, where, and when. The last one is don't give judgmental responses, because all that does is make the client feel guilty, angry, or not supported. For example, you're in the medical surgical area and you have a client who has type 2 diabetes, and you look at the results of their HB1C and you see that it's a 9. Now, in the previous 3 months, they haven't been real conscientious about following a diet or exercising. Well, you want to be real careful about how you start that conversation. You don't want to say, you haven't been following your diet, have you? Because then all it does is make the client be defensive. Okay, so that is the discussion about the non-therapeutic communication. Can't stress enough. You have to be able to recognize non-therapeutic communication in your responses when you're preparing for the NCLEX exam.
Welcome. I'm Judy Burkhardt, Executive Director of the Nursing Programs for Kaplan, and welcome to this discussion of pharmacological and parenteral therapies. This area will be 13 to 19% of the questions you see on your NCLEX exam. And we're going to be talking about blood and blood products, we're going to be talking about intravenous fluids, and we're going to be talking about medication. Let's begin. First thing we'll talk about is blood and blood products. When you talk about blood and blood products, the first thing you have to be well aware of is blood group compatibility. Remember that type O is the universal donor. They can give blood to anybody. And type AB is the universal recipient. They can receive blood from any type of other blood type. When we talk about bloods and what's given, before we talk about actually how to do it, let's talk about what is administered. You can give patients packed red blood cells, and many times this is preferable to giving patients whole blood, because they need the packed cells and the oxygen carrying capacity, but they don't need the volume. Another thing that patients can be given are platelets. Again, these are given as units and usually quite quickly. Another blood component that can be used is plasma. Again, when you give plasma, it's administered with a straight line set. Another blood component that can be administered is albumin. When you give albumin, it comes with its own administration set, and again, it's usually given quite quickly. You can give prothrombin, and again, you use a straight line with that blood component, or you can give factor VIII. This is used for patients with hemophilia. So we've talked about the different components that can be given. Let's talk about actually the implementation. First of all, before you would give any blood product to anyone, you need to make sure that their blood type has been typed and cross-matched to make sure that whatever donor blood or blood components are compatible with what the patient's blood is. You will get baseline vital signs because you'll be checking vital signs frequently throughout the administration of the blood and blood products, and you need to know where to begin or what the patient's vital signs were at the beginning of the procedure. When blood or blood products are used, they are very carefully checked by nurses, and there's a certain routine that the nurses go through. They will check the physician's order, they will check the patient's identity, they will check the ID band, they check the components and the type that is given. They will actually look at the blood, and they're looking for any bubbles or any dark color or any cloudiness. And again, before the blood is given, they would question the client quite completely about any previous blood or blood products that they had received and whether or not they had any problems when they received them before. Blood and blood products are given with a 19-gauge needle for access. Again, it needs to be that large for the blood cells, the RBCs, to be able to slide through without rupture. You always start blood and blood products with normal saline. This is the most common mistake made by new graduates, as they start it with half normal saline or lactated ringers or some other type of fluid. But 0.9% sodium chloride or normal saline is the fluid of choice to start blood and blood products. When you start the blood, you will start it slowly, and that means 5 milliliters per minute during the first 15 minutes of administration. And you will stay with the patient. This isn't something you turn it on and then come back in 10 minutes and ask the patient how they're doing. You will stay for them or stay with them the first 30 minutes. Again, slowly the first 15 minutes during this time, you'll be checking vital signs to see if there are any changes from the baseline vital signs that you've established. If there are no changes in vital signs and the patient has no untoward effects, then you will increase the rate that the blood is given. And usually blood or blood products, the RBCs and the whole blood is to be infused over 2 hours for each unit. And again, some of the other products are to be infused more quickly. What you will do is you will take the vital signs every hour while the infusion is in place. Every 15 minutes until it's established that things are stable, and then every hour, and then you'll continue to take them hourly for 3 hours after the transfusion is completed. What you're looking for is you want to make sure the patient doesn't experience a transfusion reaction. And there's several different types of reactions, and let's talk about those now. The first type of reaction is an allergic reaction, and this is due to a hypersensitivity to the blood. What you'll see with this is the urticaria, the pruritus, they may have a fever, and they may actually go into anaphylactic shock. What you'll do for this type of reaction is you give them supportive care. You'll give them Benadryl, which is an antihistamine. You'll give them oxygen. If they go into anaphylactic shock, you will do all the things that go along with that type of problem. The second type of problem is a hemolytic reaction, and this is caused by an incompatibility between the blood that was given the patient or the blood product and the patient's blood. The type of signs and symptoms that they will experience are pain in the lower back. They may become hypotensive, and again, you're checking the vital signs frequently. There may be an increase in pulse rate and a decrease in urine output, and they may have hematuria, which is blood in the urine. If the patients have a hemolytic reaction, again, you'll give them supportive therapy. You'll start them on oxygen. You'll give them Benadryl, which is an antihistamine, and you will make sure that they maintain a patent airway. The third type of reaction is the febrile reaction, and this is the most common type of transfusion reaction that patients experience. And the cause for it is that there's antibodies in the blood or the blood product that was given the patient that reacts with the patient's blood. The type of symptoms that patients will have, they'll have fever, chills, they may have nausea, and again, they may have tachycardia, which is another reason, again, remember you're checking the vital signs very frequently. Usually you will see the febrile reaction after the patient has had multiple transfusions. The last type of transfusion reaction is the bacterial reaction, and this is because you have given the patient something that was contaminated. The type of signs and symptoms you will see are hypotension, fever, chills, and the patient may develop shock. What they will do with the bacterial reaction is they will give the patient antibiotics, they will give them IV fluids to maintain volume, they may use vasopressors to maintain the blood pressure, and they may use steroids as an anti-inflammatory. Now what you will do, these are the type of reactions you may see, so what should you do if you suspect your patient is having a transfusion reaction? Well, the first thing, if you even suspect this may be happening, you don't keep the blood going or the blood product going and then check things out. You will stop the blood, you will restart the normal saline, and then you will check things out. And the first thing you will check out is to make sure that your patient has an airway, that they are actively breathing and have adequate respirations. They use Benadryl, which is an antihistamine. They may use aspirin. You will return the blood container to the blood bank. It is not something that is thrown away. And you will collect blood and urine samples to send them to the lab for analysis. And you will monitor voiding. And again, you're looking for the hematuria that may be seen with some of the blood type of reactions that we talked about. Again, the biggest thing and frequently tested on the NCLEX is you should know the signs and symptoms of the transfusion reactions, and the most common question is what should you do? Stop the blood, restart the normal saline, and then do a thorough assessment of your patient beginning with their airway. Okay, let's go on and talk about autologous transfusions. This is where there is a preoperative donation. The patient kind of banks blood for themselves because they know they're going to have surgery in 4 to 6 weeks. The good thing for this, again, is you don't get anyone else's problems, any viral infection or that type of thing. You know that your blood that you donate to yourself is compatible with the type of blood that you have. So it is used for patients that have a history of some type of transfusion reaction, or if patients have very rare blood types. So it is contraindicated. You cannot do this if you have an infection. You cannot do this if you have a chronic disease or cerebrovascular or cardiovascular disease. But otherwise, the autologous transfusion is a great way to make sure that if you know that you're going to have surgery and there's a good possibility that you're going to need blood or blood products after surgery, that you can do that without experiencing some of the complications that go with other people's blood or donated blood. Let's talk now about intravenous therapy. Okay, when you talk about parenteral therapy and IV fluids, let's talk first about some definition of terms, because I'm going to start throwing around these terms and I want to make sure we're all on the same page. First of all, when we talk about tonicity, that's the concentration of substance that is dissolved in water. So the tonicity tells you how much stuff is in the fluid. Now, isotonic fluids are fluids that have the same concentration as body fluids. They are exactly the same. They have the same amount of solutes in solution. A hypertonic solution, on the other hand, the solute concentration is greater than that of body fluids. There's more stuff in it. It's more concentrated. Hypotonic solution, on the other hand, have less concentration of solutes than are found in body fluids. And there are different times and different situations where the different types of fluid are used, and we will go through that. Now, again, a couple more definitions before we start talking about the fluids themselves. Remember, when you talk about intake is everything that goes into the patient, oral fluids, IV fluids, gavage feeding, any type of retained irrigations would be considered intake. Now, on the other hand, output is everything that goes out of the patient, insensible loss with perspiration, urine, diarrhea, vomiting, sweat, any type of drainage would be considered output. Okay, we've got our terms down. Now let's talk about parenteral fluids. The key thing to remember when you're talking about IVs is the main purpose of an IV is to restore fluid and electrolyte balance. And again, many times the NCLEX will ask you questions to find out, do you know that? Because if you've been in a hospital, on the floor recently, many people may think that the primary purpose of IVs is what is the real secondary purpose, and that is to give medications, to provide nutrition, or to provide blood components. But that is a secondary purpose for giving IV fluids. Again, when you're talking about IV fluids, you need to remember we talked about the tonicity, which is the amount of solute that is in the solution compared to body fluids. Isotonic are the same concentration as body fluids, and these are normal saline, and remember normal saline is 0.9% sodium chloride. Lactated ringers is another type of isotonic fluid. 5% dextrose in water is considered an isotonic fluid. When you talk about hypotonic fluids, you're half normal saline, and again it's the 0.45 sodium chloride, or half normal saline is a hypotonic fluid, meaning the tonicity is less than body fluids. And your hypertonic fluids, again, have a tonicity greater than body fluids. These are your D10 in water, your D15 in water, 3% sodium chloride, and sodium bicarbonate 5%. Again, these are hypertonic solutions.